Okay.
Joel Topf here from Nephrology Times. We've got a special interview here. We've got Sylvia Rosas, the president of the National Kidney Foundation.
Yeah, thank you for having me.
Oh my God, delighted to have you. So I heard it's a 2-year term for president?
That's correct.
And where are you in that term?
I am 18 months into
You can
it.
see the finish line. You can smell the barn.
Yeah, October.
It's been a pretty exciting time to be at the head of the National Kidney Foundation.
It has been. You know, there's a lot of going on in transplantation. There's a lot of new therapeutics for IgA, for membranous, for C3 glomerulopathy, everything. So it's really exciting time. SGLT2s are, all the rage.
It's a time like no other time in nephrology.
That's right. We
Okay.
went from famine to feast.
So So when you look back, you got 18 months under your belt. What's been the highlight so far as El Presidente?
And there are many highlights. I think the most important one is to understand how policy works. As we work as clinicians, we don't really understand how to get things done.
Absolutely not.
And I think the NKF government relations team is so fantastic at moving forward that legislation. We take for granted, like now we're having the transplant modernization system. And
so that's a little highlight for you right there.
That
This is a
would
pretty
be
significant piece of legislation.
That's
Was
correct.
it actually legislation or just a policy change?
Well, for the last 40 years, a single contractor has had the OPTN contract.
Yeah.
And that, in a way, kind of hindered innovation.
Sure.
Because you cannot be an expert on everything. You cannot be an expert on IT. You cannot be an expert on policy. You cannot be an expert on transportation.
And competition spurs these things forward.
We believe that is true.
Mm-hmm.
And we see it nowadays because I think things that we thought were impossible back then, all of a sudden the current contract holder is moving it ahead when, in years past we couldn't get that done. So I think that we are seeing some innovation even within the current system that we have.
Excellent.
So we have a new payment program that was just announced last week, the CFMI project. It's going to be mandatory starting in January.
What's the name of this project?
It's called the IOTA. It's the Increased Organ Transplantation acronym. Yes, thank you.
Acronym.
And
always the end is acronym. I got it. Okay.
And then so it's a way for the Center of Medicare Innovation to increase the number of transplants and reduce costs for Medicare. And it's a large document. It's over 400 pages. So we are scheming through it. It just came out last week.
And what was
on the
NKF's
9th.
role with that?
So we usually take the patient's voice and meet with CMS.
You guys represent the patient's voice.
That's right. And we tell them, okay, why, for example, we don't know that 16 offers have been made to me.
Transparency, why is that hidden from patients?
That's correct.
I love that part of your talk today. You gave the presidential keynote this morning.
Yes.
And one of the things you talked about is that patients may select which hospital to sign up for based on their risk tolerance, how willing to match their behavior or their pattern of their personality to the program.
That's right. And right now, we don't know that. Patients don't know, in this program, if I'm obese or I'm morbidly obese, I'm not going to be transplanted. But in this other center, look, they do a CT, and if my hip, now they do that, my hip to something ratio is smaller, I can be bigger, and I can still get my kidney because they use this other method.
It's just a different behavior from different programs.
Exactly, because everybody does some things differently. But patients don't know.
There's no transparency.
We don't know. So we feel that it should be transparent. If that's what you do and that's your policy, that's fine. But that should make it clear because a patient may be waiting for something that's never going to happen.
Absolutely. So then one of the other things you talked about was how the change in the EGFR formula that removed race from that formula is now has been extrapolated to transplant waiting times. So how did that work?
So initially the OPTN made it a rule that GFRs that are being used for waitlisting should not include race. That was step number one.
2021, yep.
That's correct. Well, it really happened in 2022.
In 2022, like I said, 2022.
Well, no. The equation did come out in 2021, but the
One
rule
step
came
behind.
out in
That's
22.
my middle name.
No problem. But then at the end of 2022, it was decided that the new OPTN rule was that those patients that had been affected by the race-inclusive GFR, they should get their time, and if they were still in the wait list, that they should get their time adjusted for a race-free equation. And so all transplant centers, all 230 of them, were asked, okay, review all your records of patients that could have been affected.
The new formula.
Use the
go
new
back to their old labs.
Exactly.
And see when they first crossed that line of 20.
That's correct. And so patients, on average, the median gain in time on the wait list was 1.7 years, which is a lot of time, because remember that on average, at least in Massachusetts, the average time is about 5 years. So it is, 40% of the time that they could have been waiting, etc. But there are people, like I mentioned, there was a few people that got 20 years back, on the wait list.
And I had a patient that had this. He was a patient who's been on dialysis for 14, 15 months, and I got a call from the transplant center saying, hey, your patient so-and-so, he's right at the top of the list now because we redid this calculation. And when I saw him, I couldn't describe the smile on his face. He was so excited because when you hear 5 years, it is so impossibly long. And to get zipped up to the top like that.
Exactly. And, I just want to say that helped the people that were in the wait list. But we know that the wait list is not the end game. There's a significant morbidity and mortality being on the wait list. So the most important thing is not only getting on the wait list, but transplanting as soon as possible.
We need more organs.
That's correct.
So you also talked about xenotransplant in your keynote.
Yes.
I can call it a keynote. That's a reason.
That's a presidential address.
The presidential address. That's perfect. And so super exciting things going on with Xeno. We've now a couple of brain live patients have received these pig kidneys. So we have 2 xenotransplantations done, one at MGH and one at NYU. Unfortunately, the patient at MGH. I know, it's so sad.
Yes. Unfortunately, last Saturday, May 11th, he's no longer with us. But of course, his contributions to xenotransplantations
are
valued.
Was sad at that moment.
Yes.
Like everybody came together.
We're indebted. Yes. Absolutely. Of course, we need to find out what the cause of death is, what happened. Is it the team it's now in the press release, it says it's not related to xenotransplantation. So we still have to wait for that. But we have the other patient that still received the xenotransplant.
Yeah.
She, in addition, LVAD, she got an LVAD first and then got the xenotransplantation. She's in New York. My understanding is she's still in the hospital. So we'll see how that patient does.
Excellent. Hey, is there anything else that you want to tell our readers or listeners or viewers?
Sure. So there's a lot of things interesting going on in transplantation. Yep. There are new cooling ways to try to avoid damage while we're transporting the organ. Yep. There's ways that we can pump, let's say, energy back into the kidney.
It was a very interesting aspect of your talk also, yeah.
And so what we hope is that right now we have 8,500 kidney organs that we call it discarded, but people don't want us to use that word because it's to me it's a disservice to the patients that donated.
Yeah. Yeah.
And so that's why we feel that if you donated an organ, we should do our best to transplant that organ.
We owe it to the person
that donated.
Use the kidney.
That's correct. And so we're very excited at the NKF that all of these new innovations are starting in nephrology. I think there's a lot of interest in industry, which is why we're working so hard to make new markers for clinical trials. That's why we have the endpoints like 30%, 40%, 50% decrease in GFR. Right. That was something that the National Kidney Foundation spearheaded. Now the 30% reduction in albuminuria. That's something else that was also spearheaded with support of the National Kidney Foundation. And now we're working on standardizing albuminuria with our friends at the AACC. And we hope that by 2025 that will be done. And together with our scientific workshop that will happen that same year, we will have new endpoints. Because, for example, we have data on SGLT2 inhibitors in type 2 diabetes.
Yeah.
But who's going to do a large center trial in type 1 or in different diseases, etc.?
You have a poster on that.
We are going to present some of that data during this meeting. But what I'm saying is that you could do smaller trials where albuminuria could be
What's
the
your
endpoint when you have significant data from other large studies, and then adjust. And so
if it works there, it'll work here. It's working the same way.
Exactly. So that's why we're excited about this albuminuria scientific workshop that is going on.
Hey, thank you. This is delightful.
Thank you.
Congratulations.
Thank you.